practice. In this session, we are trying to cover some of the basic aspects of electrophysiology and followed by case-based discussion. So without wasting much time, I would like to call upon our first speaker, Subhadra Jalali ma'am. So ma'am needs no introduction. You all know her for her work, which is done in retinopathy of prematurity. She also has done plenty of work on inherited retinal dystrophies and electroretinogram. So over to you, ma'am. So she will be talking on electroretinogram. From where does the signal come from?
Thank you all of you for being here. I think that post lunch we all need some electric shocks to remain alert, and that's what we are here for. So, where do these signals come from? That's what we want to know. So, we want to speak about from where the signals are coming from in terms of the cells in retina and optic nerve, and then what are the artifacts and how we look out for them. So I think over the last 50 years, we have gone from a global, like just putting a flash of light and recording some signals from the retina, to very local, like the macula, the paramacula, to very cell-specific response. And now the electrophysiology visual system is such that we can test for the on-cell pathway, the off-cell, the S cones, the rods, the cones, so many cells, and we have various tests like the electroretinogram, which can be done in various ways like flash, multifocal, chromatic, then electrooculogram, the visually evoked potentials, and so on and so forth. So we'll not be going through all the techniques, but through some of the common clinical techniques that we use. So the flash electroretinogram, where we put a flash of light and then record the responses by electrodes, it measures the changing in resting potential of the eye. So normally the eye has some electrical potentials because there are bicarbonates, chlorides, potassium, sodium out there. But when the light falls on the photoreceptors, then there's a change in this resting potential, and that is what we record from the electrodes. In general, it's a good information that whenever the retina deteriorates, the electrophysiology also deteriorates to a very large extent. So you can see here the light will fall on the retina. There will be photoisomerization, of the rhodopsin and the visual cycle. And the photoreceptors themselves will get hyperpolarized, and they will pass on these signals into the bipolar cells. Now, this is not a passive process. The bipolar cells magnify this signal, and that's why you see very large B waves, although the A waves are small. And then it is passed on to the ganglion cells and to the optic nerve. However, one must remember that this science is still evolving. There are still a lot of pathways that we don't know about, and new pathways keep on being told. So there is not like a rod pathway and a cone pathway. There's a lot of interaction between the two, especially in the inner retina, and that is where the whole processing of the signal happens. So it's not just signal is passing one place to other. So these cells which are there in the retina, they are arranged either radially or they are in between. So we can see here the general classical teaching being that the rod and the outer segments and the cone outer segments, they give the A wave, that is the downward going wave on your electrophysiology, and then when it goes to the bipolar cells where the signal is modified and advanced and augmented, it gives the B wave, which is the upgoing wave. So this is more simplistically put here. So whenever you are analyzing the electroretinogram, just remember this diagram, which is inside out. In the retina, the rays of light will pass through the whole of retina and go to the photoreceptor. The photoreceptors are the only cells in the eye which can respond to light. So whether it is any signal that you're seeing, you should know that the photoreceptors are there. If they are not there, then you cannot study the rest of the pathway. So whenever the response is normal, we are looking at a light adapted response, a dark adapted response, and then we are seeing whatever response we are seeing, it is coming from the rods and from the L and M cones and not from the S cones, because the S cones are very small, which means that if we want to study the S cones, we cannot use this bright flash. So to study the S cones, which sometimes we need a different protocol where we are using short wavelength flashes on an orange background. So like that we can study different cells by changing the parameters of the light, changing the adaptation, and so the signals from different types of cells in the retina can be amplified and seen. For example, here you can see that in a normal retina, this is how the waveform will come, but in a retina which has mostly S cones and it doesn't have L and M cones and doesn't have a lot of rod cells and bipolar cells related to rods, then the waveform will change, but still you can get a good reproducible waveform. So a normal flash ERG, when we record it in the dark adapted state, which gives us the dark adapted rod responses. Now these responses are not always directly from the rods, because the rod response will come as an A wave, but here you see there is no A wave. But what you see is a rod-driven B wave, okay, and it is amplified. That is how you will see in normal. Whereas when you put very bright light, so this is a dim light, when you put very bright light, then both the photoreceptors, that is the A wave, and the bipolar cells connected to that, both the on bipolar cells and the off bipolar cells, will give the upward going wave, which is from the inner retina. So easy to remember is that the downgoing waves are coming from the outer retina, whereas the upgoing wave is coming from the inner retina. And obviously the inner retina cannot have the waves if the outer retina doesn't function, okay. And so if the A wave is absent, then you know that the photoreceptors are not functioning. But if the B wave is absent, then you don't know, is it because the A wave is, the photoreceptors are dead, or the both the photoreceptors and the bipolar cells are dead. So you can see here, sometimes these patients, they look like RP, but this is not RP. This is enhanced Escon syndrome. It's very different from RP. It has a very, less progression, and they have very typical findings. But the ERG can tell us that this is not RP, because in RP you'll get a flat, both rods and cones, because they're coming from there. But in enhanced Escon syndrome, if you do the Escon protocol, then you can see that the signals are coming from the Escon. Now, so that was about the flash ERG. The pattern ERG, here the responses are, we are taking the responses from the macular area, because the flash ERG cannot tell you anything about the visual function or the visual acuity of that patient. It only tells you about the health of retina. So you can have an absent flash ERG, but still the patient can see 6/6. That is because the flash ERG is testing the whole of the retina, and the macula is a very tiny part of that whole retina. So when we want to look at the macular function or correlate to the visual acuity, we look at the macular photoreceptors by either pattern ERG or by the multifocal ERG. And these waveforms, they come from the photoreceptors. So here you can see the first waves, which is the P50. This is coming from the macular cone cells, whereas the N95, which is the lower part, it is coming from the ganglion cells. So there is a different origin of these two waveforms, and so these two cell types can be studied by the pattern ERG. Whereas from the multifocal ERG, here the macula has only the cone cells predominantly, so it is coming from the on and off bipolar cells, most of the signals, which are generated by the macular cones. So those who will speak on these topics will tell more details. I am just telling from where these signals are coming from. So you can see here that these signals, while they come from these cone cells, they are also influenced by what light is put before or after, because as you know, if you put light on the retina, it gets light adapted, and then it cannot respond immediately. It has to go to a dark adapted state to come back and give that signal. So if you put multiple flashes very fast, then obviously there will be a different response than if you put a dark and then a light and then a light and then a dark. So that is how this system works to give us the ultimate outcome of whether it was a light, dark, dark, or a dark, light, light, like that. Once we come to the EOG, now EOG, some people have this misconception that this is a signal from the retinal pigment epithelium, because this is what we use for Best disease, which is an RP disease. But here what we are doing is, although we are studying the change in potential of the retinal pigment epithelium, the cells don't respond to light. As I said, the cells, only the photoreceptors respond to light. So once the photoreceptors respond to light, there is a change in the electrical area or the chemical composition between the retinal photoreceptors and the pigment epithelium, and the pigment epithelium potential rises. Now if you see carefully, the potential is very big because it is in millivolts. What I was showing before was in microvolts. So the ERGs are VPs, ERGs, multifocal ERGs, they are all in microvolts, whereas the EOG is in millivolts. So once you put light on the eye, the potential of this RP changes and it rises, and that is what we call as light rise. So I will just like to say that the VP signals, again, they are not generated by the optic nerve. They are only passing from the optic nerve, and we get the response from the occipital cortex. But for VP to generate, the photoreceptors should be healthy. So if we don't know from where the signals are coming, or whether the patient is not seeing from macular disease or optic nerve disease, we must do ERG and VP, not just VP, because VP can be absent in large macular diseases also. So there are a lot of variations which can happen, which could be physiological, technical, or pathological. So before we interpret an ERG, we should keep all these factors in mind, which can influence what the waveform is. But one thing is sure, when there is a disease, the waveforms change drastically. It's not like 300 will become 290. The 300 will become 50 or 100. So that is the beauty of ERG, that the change is huge when there is a disease. So it is not difficult to pick up. Thank you.
So thank you so much, ma'am. So any questions from the audience or any comments? Basics. if there are no questions, I'll just start my talk. I'll be talking on fulfilled ERG, when to order and what to look for.
So Dr. Purnachandra is very passionate about electrophysiology, and he's a senior consultant in retina department in Narayan Nethralaya, and he'll be talking to us on fulfilled DRG, when to order and what to look for. If you have any questions, we can always take it at the end of the session as well, so please keep your questions ready.
So thank you, ma'am. So good afternoon, everyone, and thank you, Subhadra ma'am, for making my job easy. She has covered most of the basics of it. Okay, fine. So I'll be talking specifically about the fulfilled ERG, which is nothing but a mass response of a luminance stimulus, and which generates biochemical and ionic changes in the photoreceptors, which generates electrical potential, which is recorded as ERG. So I will go through some of the case scenarios where there is an uncertainty about what's happening, what's intended, and what is required. Let me start with the most commonest problem for which an ERG is indicated is night vision problem. So this was a story of 26-year-old male who presented with night vision issues. On examination, the fundus was absolutely normal. The autofluorescence and OCT was also normal. So 26-year-old without any structural abnormalities, complaining about night vision, you think of maybe malingering or some other problems. But we thought of doing an ERG on him. So we did a fulfilled ERG. If you can see here, as compared the blue ones which you are seeing is the normal one. The black line represents the patient's recordings. So here if you see, the dark adapted responses are almost undetectable. Okay. So that's the beauty of ERG, where you structurally looking everything is normal, but the ERG is telling the rod system in the entire retina are non-functional. So then the 26-year-old male presenting with a night vision problem in a normal looking fundus and an abnormal ERG, first thing we suspect is serum vitamin A deficiency. We ordered for vitamin A level. As expected, it was very low. But we are also physicians. We need to think of the reason why this vitamin A deficiency happened. Why should a 26-year-old have vitamin A deficiency? When I asked some leading questions, he told there is an history of dyspepsia, frequent loose stools and all. He underwent extensive workup to find out the cause for this malabsorption. Finally, an intestinal biopsy has to be done, where he was diagnosed to have intestinal lipofuscinosis, which is an end result of this chronic inflammatory bowel diseases. So because of which he had a malabsorption. So the ERG was repeated after supplementing the vitamin A. So we gave intramuscular injection. In case if that is not available, if you don't have any facility to take an opinion from gastroenterologist, all of you know, like we have the 25,000 international units tablets which are available in the OPD, that you can give it BD for 30 days. That also works equally well. And if you look at here, just 1 week after supplementing vitamin A, the BAV is almost coming to normal. By end of 2 months, his ERG is completely normal. So if not for ERG, not only a treatable retinal condition, but also a life-threatening condition would have missed in this case. Now coming to one more case scenario where an abnormal looking retina but the asymptomatic patient. This patient, 28-year-old male, vision 6.6, came for a routine checkup, and this is how a fundus looked. There are multiple flex-like lesion. OCT is again absolutely normal. All the layers are intact. So if you look at the fulfilled ERG is also normal. So this is a case of benign fleck retina. So most of the time these are stationary and unlikely to progress, though the retina may look abnormal. So they don't progress, and most of the time when they come for the clearance for a refractive surgery or premium hours, you can give the clearance. This is not a contraindication for any of the procedures. One more similar looking fundus, 36-year-old male, those flecks are there, not very obvious as the way you saw in the first case. This patient also had a vision of 6.6, but this patient told I have night vision problem, I have a delayed dark adaptation. We did the OCT again structurally it was absolutely normal. Now look at the ERG, the dark adapted responses are almost undetectable. If you look at the combined responses, there is something interesting happening here. The A wave is forming, the B wave instead of going like this, it's getting terminated here itself. It's not even reaching the baseline. So this is the classic electronegative ERG what we see here, and its light adapted responses are quite okay. So this is a case of fundus albipunctatus, which is a form of congenital stationary night blindness. Okay, there are many other things. Basically, there is some problem with the bipolar cell transmission, and B wave is from the bipolar cells. That's the reason we get electronegative A wave. So this is again to summarize, the both almost similar looking fundus, but the ERG once you do, both are completely a different entity. And second one, as I told, it's a stationary disorder and it's not going to progress, unlike an RP, not to get confused with RP related night blindness. Fine. Then normal looking retina with an unexplained visual symptoms. This was a 26-year-old female, recently married, brought by husband because he was quite inattentive to the surrounding, and there was no positive family history. Vision, she was giving variable responses whenever he checked the vision. We still today we don't know what's her vision. Anterior segment, posterior segment, everything was normal. And this is her OCT. I'm showing you all the cross sections. Absolutely normal OCT. Autofluorescence also near normal. So what do you suspect? Recently married, brought by husband, everything is normal. The first thing you suspect is maybe malingering. Okay. So, but you should not label any patient as malingering without subjecting them for an electrophysiological test. That's what we did in this patient. If you look here, the light adapted responses are undetectable. So whereas the dark adapted responses are, my cursor, yes, it's absolutely normal. If you look at the light adapted responses, it's an undetected, it's a flat line. So what OCT is telling is everything looks normal, but the ERG is telling the cone system in the entire retina are non-functional. So this is a case of achromatopsia, which is a form of stationary cone dystrophy. So this is the kind of OCT changes what we usually see, which resembles a photic retinopathy, but our patient did not have that also, which is quite common in this cone dystrophy kind of disorder. One good thing about this is again a stationary disorder. It's unlikely to progress and it's not a blinding condition. All they need is photochromatic glasses, some little bit of counseling and low vision aids. Then one more category, very common, having taken multiple opinion, what's wrong with my eyes? This is one such story. This was a 25-year-old male, had a night vision problem, no positive family history. Best corrected visual acuity was 6/9, color vision was normal, anterior segment was also absolutely normal. So when he draw the pedigree, he was born out of a consanguineous marriage. He had one more brother who did not have any issues. So this was his fundus photo. When I saw that, I was very happy. This is a very classic Mizu-like reflex. So I thought maybe I'm dealing with one of those CSNBs or Oguchi's disease. Then I ordered for an ERG OCT testing just to make document. So this is the wide field autofluorescence. There was some autofluorescent ring in the periphery with small flex-like deposit nasal to the disc, more prominent in the left eye. So this is the same autofluorescence of the posterior pole. When I did an OCT, there are some interesting changes in the perifoveal region. There are some skytic changes which should not be there if it was a congenital stationary night blindness group of disorders. It should be normal. Okay, so then I thought of night vision problem, skytic change, maybe it's a juvenile retinoschisis. Then I thought, okay, I'll do an ERG, I'll get electronegative ERG, I'll report and give it to you. Then when I ordered an ERG, I was in for a surprise. There was no electronegative ERG. So there's a gross reduction in dark adapted responses, and dark adapted combined responses are also delayed and decreased in amplitude, and same thing was seen in light adapted responses. There's one interesting thing to observe is the dark adapted 3.0 ERG and light adapted 3.0 ERG looked very similar. And I'll tell you, this is very specific to one condition. I'll explain that. So then these are the scenarios where we need to do some of the extended protocols which Subhadra ma'am just told. So that's what we did here. We stimulated the long and medium wavelength cones. We gave them the blue background to silence the short wavelength cones, and we stimulate the retina with the orange light, long wavelength. For that, what we got is an undetectable response. When we did the opposite, like we use the orange background, stimulate with the blue light, what we got as a enhanced response. So this is a classic case of enhanced S-cone syndrome. So there are few conditions like ACNV mutations and enhanced S-cone syndrome where ERG is the diagnostic. You need not even go for the genetic testing. So to conclude, I would like to say electrophysiology is an important tool to aid the diagnosis in various diseases. It should always be followed by clinical correlation and another imaging modality. Don't take this in isolation. And additional genetic information in case of dystrophies might help. Thank you so much.
Excellent talk, Purnachandra. We'll go to the next talk by Dr. Praveen Sen, who will speak on multifocal ERG and pattern ERG. If you have any questions, just keep them and we'll take all the questions together. Great.
So very good afternoon to everyone, and many thanks to the AIOC Scientific Committee as well as Dr. Purnachandra for his efforts to put this session together. So Dr. Ma'am and Dr. Purnachandra both have spoken very well on full field electrophysiology and what are the origins. So one limitation of full field ERG is that, as the name suggests, it gives the mass response, and we've all heard and read that almost 50% of the retina has to be malfunctioning for it to show any response or any effect on the full field electroretinogram. So what happens in macular dystrophies? A macula, we know, forms less than 10%, and if there is a macular dystrophy, the patient will have poor vision yet your full field ERG would be normal. So to address these conditions, we have special tests, which is the multifocal ERG and the pattern ERG. So the need, as I said, the need is to display the topography or the malfunction in the macular area, which may not be picked up on a full field ERG. Also, full field ERG gives you the option of seeing both the rod as well as cone photoreceptor function, but multifocal ERG is largely cone driven because it is done under light adapted conditions. And as I said, it is the entire retina which is measured in full field ERG, while in multifocal ERG it is the central area or the macula which is determined, the health of the macula which is determined. Principle, it is done, how it is recorded: pupillary dilatation, light adaptation, and room illumination, and we have various stimuli which can be used. I'll show you the specific stimuli, and the electrode used is the Berin-Allen electrode. And fixation is of utmost importance because it is giving you topography. If the patient is fixating elsewhere, the whole topography changes. So the fixation should be monitored throughout, which can be either in form of crosses or rim spots in the center, and the refractive error correction has to be in place. This is the special kind of stimulus which is used for multifocal ERG. It is called the random or the pseudo-random actually. Why pseudo? Because it looks random, but there's nothing random about it. It blinks and changes from dark to light according to a set algorithm, so much so that it ensures that 50% of the hexagons are on and 50% are off. And even the size of the hexagon is scaled, so you can see that the size of the hexagons is smaller in the central area because here the density of cones is more. So each hexagon is stimulating equal number of cones across the central 40 degrees. So you could have 37 stimuli, you could have 61, you could have 103 or 241. So how do you choose? So in a non-cooperative patient, 61 is much easier because time taken is lesser, patient cooperation required is lesser, but only thing is that the resolution that it will give you, it's almost like the pixels, so the resolution that it will give you is less, and the smaller area of disease may be missed. It can also give you in form of ring that 0 to 1 degree or 6 degree, how much is so which area, is it the fovea involved or the perifovea or the parafovea which is involved. This is one of the we all look quickly for this, but actually though it looks very pleasing when you look at, this is not the best way of interpreting multifocal ERG. The best way is to look for the trace arrays. So, but it quickly gives you the distribution. It tells you whether the superior area retina is involved or inferior is involved. Dr. Subhadra spoke about the origin, and it is first thing to remember, it is cone driven. Why? Because it is always done under light adapted conditions. The P1 and N1 waves are almost similar to A and B wave of a full field ERG. Why I said almost? Because it not only depends upon whether it is light flash or dark flash, also depends upon whether the previous flash was light or dark. So it is a kernel or a mathematical algorithmic extraction which is given to us. It is interpreted in the same way, where N1 is usually represents the A wave, and it comes from the photoreceptors, and a decrease in amplitude suggests cell death, whereas delay in implicit time or latency is usually suggestive of malfunction. So this is some typical form of MFERGs, where you could have central defect, the periphery is normal, something like a Stargardt's disease, generalized peripheral abnormality, only central preservation, typical of RP, generalized reduction, which is seen in cone rod, that both cones and rod affected, and localized, say here the inferior field is affected, what you may see in a branch retinal vein occlusions. Very mindful for artifacts, because artifacts can be very often seen in these cases of MFERG, and typical is this, the second one here, where you may see that waveforms are there, but this three-peak waveform is nothing but electrical noise. This is how it looks. So you must get used to identifying the waveforms, because you may get a topographical map with even this kind of a noise. Here you can see that waveforms in the superior area is much better than here, but this is nothing but eccentric fixation. Just taking you to a few examples here to look at. Both the retina look almost similar, but if you see In fact, the ERG also looks similar because in the early stages of cone rod dystrophy in a young patient, the cones may not be so subnormal, but you see that MFERG is already non-recordable. And Stargardt's disease, you can see that the central area is the one which is depressed, but the periphery is better. Retinitis pigmentosa, as I showed, that the central area responses may be better. In fact, this is again very, very useful because in our latest cases of gene therapy, the only way you can find out whether the gene therapy is working or not is by doing an MFERG. Why? Because full field ERG still remains extinguished, and for you to see any measurable change in gene therapy, I think we are very far away from that endpoint. So in occult kind of macular dystrophies also you may have only MFERG which can help you determine the dysfunction, because full field ERG may be normal. MFERG is vital in drug toxicity, especially in cases of hydroxychloroquine toxicity, where this test is one of the preferred tests for looking at the toxicity in addition to OCT. Chloroquine toxicity is another one. Without going into too much of detail, you can see that the central areas are affected early on. Hydroxychloroquine, as I said, that this forms one of the recommended screening tests for why I think OCT is coming ahead of MFERG is sadly the availability of OCT is much more than MFERG. So they say that OCT is a must. MFERG, wherever possible, actually it will give you a better and earlier affection. Vigabatrin is used as an anti-epileptic, and it is known to cause visual field defects. Sometimes children find it difficult to respond to this kind of a test of perimetry. In them, multifocal ERG can also be done, and it is more sensitive. And desferoxamine toxicity, this is also again another more than drug toxicity. There are some acquired or non-congenital disorders of retina also which can be picked up on MFERG. In fact, MFERG was one of the first tests which first told us that central serous chorioretinopathy is actually not only a macular disease but a widespread affection of the retina, because whenever MFERG was done in patients of CSE, you saw widespread affection of the responses. Diabetic retinopathy, MFERG is again very much into the forefront now. Why? Because even in patients without an obvious diabetic retinopathy visible clinically, the MFERG is affected, and this corresponds to the areas of affection. Healthy areas may actually have normal MFERG, while unhealthy may have affection early on. In neurodegenerative diseases like Alzheimer's as well, MFERG has been shown to be abnormal right in the beginning. Most important caveat for me is do not try and interpret MFERG without first looking at the full field response of the retina. If you document that that is normal and then go to MFERG, it will make a lot more sense. Just another couple of minutes I will introduce you to pattern ARG. I can't tell it in detail. And it is recorded by using detail electrodes, two components, the P50 and N95. The importance of pattern ERG is that it delineates the macular dysfunction from optic nerve dysfunction, where P50 shows you the macular dysfunction, N95 shows you the optic nerve dysfunction, and in optic nerve diseases, selective loss of N95 will happen. In macular diseases, P50 will be reduced in addition to a decrease in N95. So why pattern ERG and not ERG for optic nerve dysfunction? Because whenever you give a stimulus in form of a pattern to the retina, it is the function of the ganglion cells to pick it up, which is why the pattern ERG is coming into the foray. So just as I said, that P50 is if you have a full field ERG which is normal but P50 which is down, it is a clear indication of a maculopathy, right? So it complements full field ERG. And most important, this is something which you may think, why not pattern VEP as well? So here, look at it. This is just macular edema, but what is happening to pattern VEP? It is already down, which is because large part of optic nerve is formed by the decussating fibers from the macula. So if macula is abnormal, pattern VEP automatically will become abnormal even if the optic nerve is healthy. So only if pattern VEP is down along with a decrease in N95 can you definitely say that it is optic nerve dysfunction which is causing it. And the typical example, which I'll share with you, only one example, is that of pattern ERG in acute optic nerve demyelination or optic neuritis. We know that within the first 3 weeks it will be unrecordable. Why? Because first 3 weeks you have a sudden drop in vision. So when the visual acuity is poor, eye does not recognize the pattern, and all P50, N95, all components go away. But as the visual acuity improves, you have improvement in P50, but N95 remains subnormal. So this is typical that this is an optic nerve disease that you are looking at. So that's all for today. Maybe thank you.
Thanks, Praveen. So we now know, what we need to do to look at the macular function and the peripheral retinal function as versus the structure. Now it's time for Simar Ranjan Singh from PGI Chandigarh to talk to us about the electrooculogram. Again, a very important technique to understand the function of the outermost layer of the retina, that's the retinal pigment epithelium, which while we do study with autofluorescence, but as we saw in different examples, the structure can look normal, where the function will be abnormal. And how do we check for these functions in the presence of either a normal looking eye or an abnormal looking eye? So electrophysiology unlocks a lot of mysteries of patients seeing different from what the doctor is seeing. And that is the beauty of it. And of course, for myself, it's the tool that I'm going to use when I have Parkinsonism. I can't operate. I can still, stimulate my brain cells to think of what the patient has by doing this beautiful technique of electrophysiology, which I think will stand to me even when I will not, be operating. So I think everybody who works with patients, whether it's general ophthalmology or retina specialist or pediatric ophthalmologist, they should have a pretty good idea of the electrophysiology, because that's what the eye sees. And now we have handheld tools. There will be a DSTC. I'm running it on Saturday, and somebody else is running it on tomorrow in the diagnostic center. And of course, there are all the companies displaying their electrophysiology equipment. Previously, we had a lot of problems of getting them to India, but now a lot of companies are selling, and I think there are a lot of centers which are doing electrophysiology. So it's good to learn these techniques, even if you're not doing, but to understand what the test means, because the patient will come with the report, and then you should not look lost. And if you don't know, just say that okay, there is somebody else who can interpret this report for you. But we should know where these things work. And meanwhile, I think there's some glitch. If there are any immediate questions, we can take questions while we have the talk. Anybody wants to ask any questions? Go ahead.
So I want to ask, if you have a normal pattern ERG and a normal multifocal ERG, that means the retina is functioning fine. Because I'll just the question is, I have a 20-year-old with bilateral temporal parallel 6/120 vision. Now I thought it is LHON, but when you get all those testing and when I get the genetic testing done, it comes to be COD. Father is positive for COD. It's autosomal dominant, heterozygous, but the electrophysiology is absolutely normal.
So how old is the child?
20.
Yeah, so COD, it comes in the second decade of life. So if you have multifocal ERG, may not be normal actually, especially if the vision is 20/200, you said, right?
Yeah.
So with that kind of fixation, maybe the fixation is not proper or something. Multifocal ERG should be down. Pattern ERG, you have to see the field. If it's a smaller field that you're doing, you may find that it is normal. But actually, with that kind of vision, pattern ERG should be low. It should not be normal.
So both are
and I think Praveen has talked about the artifacts that
It
sometimes
must be,
the multifocal ERG can look normal, but you have to look at the waveforms. That is very important. If you just look at the signals, sometimes there will be huge signals, but these are all artifactual. So whenever we interpret electrophysiology, just like we interpret field, first is to see the reliability and to see that each waveform is proper. So the signal to noise ratio has to be looked for. And then only
a vision of 20/200 and normal pattern ERG and multifocal. In fact, I would say pattern ERG should be non-recordable.
Yeah, but if it is so, that means that the patient has serious optic nerve disease. If
that
your
we were
macula is
thinking,
looking
yeah,
normal,
so
everything is looking normal.
And
OCT
COD
is
means
okay.
full field ERG. How was the full field ERG?
It's normal. Then we got the multifocal after that.
Yeah, so if all these tests are normal, then you have to really think that is there genotype-phenotype
Yes,
correlation. Then you need to
absolutely.
look at the optic nerve function.
That's right. So that's
You
what I
know,
wanted to
yeah.
know regarding the ERG.
Yeah, so
Yeah,
then
with
even the genetics can be false positive,
True.
false negative. So the whole story has to be put together. What's the color vision, when it starts, what's the family history, and as we know, the diseases don't follow books. So it's up to the clinician to bring the whole story together and say what is happening to this patient, and we can get the answers if we interpret each part of the puzzle.
Actually, that's one of the limitations of pattern ERG, that in patients who already have very low vision, there's no point doing a pattern ERG. You can't record it.
They won't fix it. Okay, Simar, you're set.
Right. Thank you, ma'am. And thanks to AIS Scientific Committee for giving this session. So, in testing the retina, I think we have tested the whole of the retina. We have tested the macular part. We've tested the photoreceptors. It's now time for the RPE, which is primarily tested by the electrooculogram. So we've heard about the other tests that are listed here, which test the rest of the pathway. Electrooculogram is a measure of the function of the RPE. So our eye is like an electric dipole, with the cornea being positive in the front and the RPE being negative at the back. And it is this difference in the voltage of between the positive and the negative side that we are trying to measure with the electrooculogram. And how we do that is by making the eye move from one direction to the other. The positive changes to the negative and henceforth, and that difference that comes with the movement of the eye is what we record as the RPE potential, trans RPE potential, and this is a measure of the RPE function which we get with this. So just going over the technique, basically on the electrophysiology machine using a Gans field. First you get the demographics right, get the patient right, and then you select whether you are doing it in a dilated stage or an undilated. This is a test which is to be done in a dilated state, with the patient being in a room light condition for at least 30 minutes prior to the test, and you don't want to do any flash photography or indirect examination prior to doing that test. This is cleaning the skin areas where you want to put your gold cup electrodes so that your contact is proper, you have low resistance. And there are two active electrodes on the inner and the outer canthus of each eye, and the ground electrode right at the forehead. Once you have cleaned the area, you put in the active electrodes and the ground electrodes, take them away from the field of the vision of the patient so that that is not obstructed. So these are the two active electrodes for the left eye, and similarly two active electrodes, gold cup electrodes for the left eye, and you check the resistance. That should be under 5 ohms, and this is the setup that the patient has. And then you convert it into a dark room, and the patient is placed on the Gans field, and I'll just show you what the patient sees. So these are 3 lights that you can see. The red light that is there in the center changes between 15 degrees to either side of the right and left side, and you can see that red light flashing. And similarly, the patient has to be instructed to follow the red light when it is shifting, and to shift only when the light shifts. So accordingly, you are seeing the voltage potentials that are recorded each time the movement takes place, and the difference that comes once we turn on the lights of 15 minutes of dark adaptation followed by 15 minutes of light adaptation. And once the light adaptation starts, the difference in the potential starts to go up, and that is the light peak to the dark trough that we want to measure in this. So 2 steps to this. After putting in the electrodes, take the patient in dark adaptation, 15 minutes in that, and then switch on the Gans field light that is there, and that slowly the patient light adapts and the potential keeps going up, and you record that. So again, for interpretation, as we talked about, confirm the demographic details, make sure you are not doing a wrong recording. Look at the saccadic records that are present. These are displayed separately to make sure that the patient was cooperative during the examination. And improper recording may be seen in patients with poor fixation, ocular motility restriction, nystagmus, lot of photophobia, poor attention span, or if at the end of the day it's a fatigued patient who is simply not following the light. Interpretation, again, during the dark phase, the potentials will slowly go down, and between 10 to 15 minutes of your 15-minute phase, you'll get the dark trough, and the light peak usually comes after starting the light phase within 7 to 12 minutes, and the ratio of the light peak to the dark trough, which was originally known as the Arden ratio but now preferred to be called as the light peak to dark trough ratio, normally should be between 1.7 to 4.3. So anything abnormal beyond that is something that we are looking to interpret in this. So just 3 cases to demonstrate how the electrooculogram helps. This is an 8-year-old girl who presented with complaints of low vision which were detected during school screening. Vision 6-9, best corrected in both the eyes. You can see some yellowish deposits here which are present with detachment of the posterior pole. Autofluorescence helps a lot in these cases as these vitelliform deposits kind of light up on autofluorescence. So this is indicating towards a vitelliform disorder, yes. OCT also shows you those elongated photoreceptors, shaggy photoreceptors, some focal choroidal excavation here, and a lot of deposition of this vitelliform material. So whenever you are doing the electrooculogram, it is very important to have a full field ERG which is done along with, because as we talked about, the photoreceptors are the only cells which are sensitive to light. So if your photoreceptors are not normal, your electrooculogram will be reduced. So once you have documented that your full field ERG is absolutely normal, only then you go on to interpret your electrooculogram and not otherwise. So here you can see the full field ERG because the rest of this retina was absolutely fine functioning. That is normal, and then you go on to the electrooculogram which shows you a reduced light peak to dark trough ratio of about 1.2, and the genetics confirmed this to be a BEST1 mutation, autosomal dominant, compatible with BEST disease that we see typically in children. The second case, a little older girl, 21-year-old girl, again complains of low vision, 618 OU best corrected, and you can see here the abnormalities are a little more widespread along the arcades and a little beyond them also. And again, the electrophysiology gives you a better measure of how the abnormalities really are, and you can see this the autofluorescence gives you a better measure, and the hyper autofluorescence signal going way beyond the arcades till there. And so this picture does look like what we call as autosomal recessive bestrophinopathy, again a manifestation of BEST1 gene. The OCT looks similar with some shitic spaces along with in the retina, along with those elongated shaggy photoreceptors. Again, to confirm, you do an electrooculogram with a full field ERG. Here if you see the full field ERG, it is slightly reduced because the extent of the disorder is beyond the macula and involving the whole of the retina. So the full field ERG is slightly reduced in this, but the electrooculogram is grossly abnormal, which shows you an Arden ratio of about 0.86, and genetics confirms autosomal recessive homozygous mutation in the BEST1 gene, which confirms autosomal recessive bestrophinopathy. So where it helps more in confirming whether it is not BEST is in cases which adult onset foveo-macular dystrophy. This was a 59-year-old male diagnosed as CNV elsewhere, injected with bevacizumab in both the eyes, and 636, 624 vision best correcting to about 612. And this is the picture that you have. Again, you have that vitelliform material deposited right at the posterior pole, both in the right as well as the left eye. So this is what was suspected as a choroidal neovascular membrane, and the anti-VEGF injection given. You can see the OCT is very similar with a lot of vitelliform deposits and elongated photoreceptors, and the OCTA confirmed that there was no neovascular membrane here. But when you do the EOG, that clearly shows that the EOG is absolutely normal. It had a light peak to dark trough ratio of 2.2, and this is typical for adult onset foveo-macular dystrophy. So BEST1 gene spectrum is where we mostly use the electrooculogram, and it helps differentiating BEST from pattern dystrophies as well as the adult onset variant of vitelliform. Typical BEST, you would have a full field ERGs that is normal and a EOG that is abnormal. Autosomal recessive BEST and autosomal dominant Adveric, you would have a grossly mildly abnormal full field ERG but an abnormal EOG, and in adult onset you would have a normal full field ERG along with a normal electrooculogram. So that way you can help and differentiate this and order targeted genetic testing. Thank you.
So we have the last talk, which will be on the video. Can you please play that? Simar, thanks. It was very nice. So this is
Dr.
by Shrikant
Shrikanta could
Padi,
not make
who
it due to
is
some
from
family
our
issues.
Good
Bhubaneswar
afternoon,
Center of
everyone.
Ravi Prasad.
It's a pleasure to conclude this enriching session. We have seen how electrophysiology unravels the mysteries of retinal disorders. And now, let's bring it all together with some real world cases where electrophysiology was truly indispensable. Let's go to case number 1. A 35-year-old male fireman presents with progressive distance vision for 5 years. His color vision test shows he could only read 17 out of 23 Ishihara plates in both the eyes. The best corrected visual acuity was 20 by 40 in his right eye and 20 by 20 in his left eye. The intersegment examination under slit lamp was unremarkable. Here you can see the fundus image of the right and left eye. While grossly the fundus appears normal, one can appreciate subtle RP changes along the arcades. Also, the foveal reflex was appearing dull. So what's next? While the structure looks fine, could there be a functional issue? Here is the autofluorescence image. Notice the granular hyperautofluorescence along the arcades, also in the peripapillary region. And this kind of hyperautofluorescence was symmetrical in both the eyes. So this pattern raises a suspicion of inherited retinal dystrophy or some kind of toxic retinopathy. Now let's examine the OCT scans. We see a bilateral subretinal and intraretinal hyporeflective spaces. The intraretinal hyporeflective spaces were localized to the outer plexiform layer and outer nuclear layer. And all these features in both the eyes were bilaterally symmetrical. To further investigate, we assess the patient's detailed history. There was no history of parental consanguinity, there was no family history of similar illness, and no significant medication history. However, there was a history of tobacco addiction. He was treated as a case of central serous chorioretinopathy earlier without much benefit. Full-field ERG reveals subnormal cone and rod responses in both eyes, measuring approximately 70% of the normal lab standards of ERG amplitude, indicating a global photoreceptor dysfunction. Additionally, we performed electrooculogram, which revealed an absence of light peak, suggesting severe RPE dysfunction. We perform genetic testing. Whole exome sequencing confirms an autosomal recessive mutation in the BEST1 gene. So what's the takeaway? Remember, a key distinction in electrophysiology is that in best vitelliform macular dystrophy, EOG is severely reduced, but ERG is relatively preserved. However, in autosomal recessive bestrophinopathies, both EOG and ERG are severely reduced. Next, we'll discuss two boys, both 8 years old, with a best corrected visual acuity of 20 by 100. They present with complaints of blurring of vision along with very minimal nyctalopia. Interestingly, both the boys share a similar looking fundus appearance. This raises the question, are we dealing with an early onset inherited retinal disorder? So let's analyze their imaging and electrophysiological findings to uncover the diagnosis. Here you can see the color fundus photograph, autofluorescence and OCT of patient number 1. On a deeper look, the autofluorescence imaging reveals 3 key features. First, presence of macular atrophy with classical peripapillary sparing. And also, you can also notice there is a classical amoeboid pattern of atrophy extending throughout the fundus. We perform the electroretinogram, which shows both rod and cone systems affection with a predominant cone dysfunction. Similarly, when we examine BOY2, this is the color fundus and autofluorescence imaging of BOY2. On cursory look, you will also see three classical autofluorescence finding in our second patient. It reveals macular atrophy with peripapillary sparing. However, a distinguishing feature is that there was presence of fishtail flex. Interestingly, when we performed the full field ERG, it showed a near normal scotopic response with only a slight cone affection, which was approximately 30% of the 30% reduction of the normal left standard. This subtle dysfunction suggests that a different disease spectrum compared to the other boy. We went ahead with genetic testing, and genetic testing identified distinct diagnoses for both the boys. Boy 1 had RDS12 related Leber's congenital amaurosis, explaining the early onset visual impairment and nyctalopia, and boy 2 had ABCA4 related cone rod dystrophy, which aligns with his imaging and electrophysiological finding. As we have seen throughout these cases, electrophysiology plays a crucial role in unraveling the complexities of inherited retinal diseases. It allows us to detect functional deficits even when structural imaging appears normal, guiding us towards the correct diagnosis. However, it is essential to remember that electrophysiological tests should never be used in isolation. Instead, they must be interpreted in the context of clinical findings, multimodal imaging, and genetic testing to form a comprehensive diagnosis. Thank you very much.
I think I'll thank Dr. Padi, though he was not here. He has done well to drive home his point, how we can effectively use these electrophysiological tests to solve the mysteries of IRD. I think I would also encourage some questions, but one comment is that not all tests are required in every disease. So it's not that you try to do full field ERG, MFERG, pattern ERG, EOG in everything. So you need to know which test to advise and which conditions. So clinically you must evaluate your patient. So suppose you are having an optic nerve disease. So you would start with VEP, pattern ERG. This would give you a good comprehensive information of what kind of optic nerve problem. If you have an inherited retinal dystrophy, you'd probably advise an ERG with multifocal ERG to begin with, and of course a pattern ERG to rule out any other, whether it is a macular dystrophy or it's a full field dystrophy that you are dealing with. EOG I think can be reserved largely, as Dr. Simar also explained, for this best dystrophies which are very well easily distinguished by the affection of ERG and EOG. Any questions from the audience or any other comments from my colleagues?
Ma'am, if
Yes,
we
please.
discussed about multifocal and pattern ERG, would you give us any pointers when to order which one? Whether normally in the workup of a unexplained visual loss, which one would you order first and then maybe go on to the second one? Or would you reserve multifocal for drug toxicities and when you want to monitor progression specifically?
So that is something which we were talking, that you should know which test to advise where. So pattern ERG, in fact, most of the protocols in the Moorfields Hospital also, they believe that you start with pattern ERG. The moment you do a pattern ERG, because it has to be done undilated, so you already are looking at whether it's you are ruling out whether it's a retinal problem or it's an optic nerve problem. So suppose it is N95 is down, P50 is good, you already know that you are probably thinking of an optic nerve problem, in which case scenario you can go on with doing your VEP and pattern VEP in case of unexplained visual loss. But if you are seeing that the P50 component itself is down and pattern ERG itself is down, then once the P50 is down, N95 also becomes down. So in the case of maculopathy, you could have affection mostly that P50 and N95 both are affected. So in that case scenario, you can go in and do your full field ERG and multifocal ERGs. So if you start with pattern ERG in this way, this could also help you find out which way you need to go.
So I want to add to that is that any of these tests, it requires a good technician and a good clinician. So do the tests for which your technician is trained. Suppose they are trained, because actually to get good pattern ERG is more of a technical challenge than to get a good multifocal ERG. So it took us a lot of time to establish the standards and the norms for pattern ERG as compared to multifocal ERG. So no, so each technique is not the same. Flash ERG is much more easier to establish. So that's one part. Second part is, in our center we have made pattern ERG as a part of our basic ERG. Because if we do only flash ERG, then we don't know what is the macular function. So when we charge the patient or we write for ERG, it includes pattern as the first one and then the flash, so we get all the information. But of course, if the patient already has nystagmus or cannot fix it, then we know that whatever pattern ERG we get, although they record it as part of protocol, but we have to ignore it because it will not be suitable for that patient. And multifocal ERG usually we are doing, of course, after knowing that the patient is stable. In small children you can't do it. We usually reserve it for the toxicities. And why it is that is because it's the ring change, the perifoveal ring change, which is the most common affected area, especially in hydroxychloroquine toxicity where we are studying it. And that ring you cannot get in the pattern ERG. So pattern ERG can sometimes miss very small lesions because the check sizes are larger, whereas the multifocal ERG is a scaled pattern. It conforms to the density of the photoreceptors which are there. Okay, so when you do multifocal ERG, you are getting more topographical information than you get in pattern ERG. But some machines, when you buy the machines, you know, the cost is different when you want to put in multifocal ERG. So your normal flash ERG can do your pattern ERG, pattern VP, but for multifocal you need a separate, process. So if you don't have multifocal ERG, it doesn't matter. Your pattern ERG will pick up most of the serious macular disorders. It may not pick up very tiny, subtle disorders. So I think understanding the usage, the limitations of each of these techniques and how they are done and how we interpret, just like any other technique, some people will do great SICS, some people will do great phaco. Both are good, right? So it depends on the surgeon. Same way here, it depends on the clinician and their team, and what type of patients come to your clinic, what is the question you are asking. That should be very clear. After you do the clinical examination, it should be very, very clear why you are doing a particular test. It's not only for ERG. What is the question we are asking? Are we asking, is the patient seeing, not seeing? Are we asking, is there toxicity or no toxicity? Are we asking that is there a macular dysfunction or an optic nerve dysfunction? Are we asking that, is there nutritional deficiency versus a trauma effect? So depending on what's the question you're asking, you can very well use these techniques because they get affected very severely when there is an underlying pathology. So there's complete mathematical science to it. So I think we are just on time. We have time till 3:30 and it is 3:27. So we have another 2 minutes if anybody has any more questions or comments. Otherwise, we'll thank you all for being here. It was wonderful to see a full house. Thank you so much. We can take a, we have already taken a.
We can take 3 of us together.
Yeah.